Welcome everyone to Women's Health Techs Wednesday. I am your host, Nina Joshi, and I am very excited to bring on today's guest, Jina Dcruz, who is the lead health scientist over informatics at the CDC. Thanks so much for being here.
Thanks, Nina. It's my pleasure and privilege to be here. Thanks for having me.
Yeah, absolutely. Well, would love if maybe we can start things off by just having, a formal introduction and just a little bit of background on yourself.
Absolutely. So again, hello, everyone. I'm Jina Dcruz. I like to call myself an interdisciplinary scientist who works at the intersection of public health, informatics, and data science to advance population health outcomes. I know that's a mouthful, so I'll try to sort of outline what I've done, both academically and as my work experience. And maybe also kind of give you a little bit of background personally. So I was born and raised in a very small state in the southern end of India called Kerala, which routinely kind of gets listed in National Geographic places to visit. So if any of you want to visit, please holler and I'm happy to connect. But now I proudly call myself a global citizen. I have a PhD in behavior sciences, and I completed an applied postdoctoral fellowship in public health informatics with the CDC. It's called the CDC Public Health Informatics Fellowship Program. And post the fellowship, I continued working at the CDC as a health scientist, and now I serve as a lead health scientist informatician at the CDC. As a disclaimer, I'm not representing the views of my employer and are purely sharing my personal perspectives today.
Perfect. Wow, that is quite a journey, and that sounds incredible. Would love if you could share a little bit more. I know you kind of spoke about your work in academia, kind of the PhD. Would love if you could share a little bit more kind of about your journey that has led you now to the CDC. Was it something that you were always interested in being a part of, or did you kind of find yourself with an opportunity like this?
That's a great question. And when I talk through how I landed here, you would kind of see I was just at the right place at the right time with the right people, to be honest. So let me start from the beginning. So I kind of completed my undergraduate education and postgraduate education in India. So I did my undergrad in psychology, economics, and sociology, and master's in medical and psychiatric social work from Tata Institute in India. And both of this disciplinary backgrounds kind of helped me build a very solid foundation in social sciences. And I was more interested in international development work. So I have done many roles in my career. So I started my career as a behavioral counselor because of my social work background. Then I moved on to become a researcher and a monitoring and evaluation consultant, primarily with various consulting and international development agencies, including UNICEF, UNDP, the Hunger Project, and so on, and worked in different regions in South Asia. So I primarily worked in the area of maternal and child health, education, and microfinance projects in underdeveloped and underserved areas, specifically with marginalized populations during that time. During the course of my work, I noticed how simple technology, like, for example, laptops in a rural school, rural school, or mobile phones for data collection, how it really makes a tidal change in the course of intervention and policy application. And because of that, I really became interested in information and communications technologies, specifically in health and education. That's why I wanted to pursue my PhD, and I came to US to do my PhD in behavior sciences to kind of align with my subject matter expertise. And I was doing my PhD in UT Health, and with UT Health, you had the benefit of having multiple health disciplinary schools in the same location and also having satellite campuses. So we were able to take any number of courses in any number of disciplines and also have experience in a lot of applied projects. So I was involved in multiple projects that kind of married public health and technology. For instance, I managed projects that design computer games for adolescent sexual health education. I also received an ARC HRQ fellowship that was focused on improving patient quality outcomes that helped me go to Brazil to work on a couple of telemedicine projects. So every single project I worked on kind of had this flavor of public health and technology. And my dissertation was also on designing computer games for adults in sexual health education and how that affects your behaviors. So this experience kind of made me help make me decide that, okay, I want to pursue this path, but I didn't necessarily want to do academia. So I was searching for something that would give me that opportunity to continue in that path. And specifically within the public health domain. And that's how I chanced upon the CDC Public Health Informatics Fellowship. And again, to be honest, I was not really qualified or eligible to apply for the fellowship, but I just gave it a chance, applied for it. And I was fortunate to be in that cohort, which had only 4 people from entire US, and they also pick fellows internationally. And at the fellowship, I actually had the fortune to work on many applied projects, which was really aligned with my interest area. So I worked within US as well as across the world. I have supported technical assistance projects where we have evaluated health information systems, designed dashboards for public health monitoring, worked on multiple emergency responses. So it was really perfect fit for what I was looking for. And then I continued on at the CDC. So I started as a fellow, and then I sort of transitioned to become a health scientist with the same fellowship. So I was training and doing curriculum development for a while. Then I moved on to epidemiology and laboratory capacity development, more sort of in the workforce development space. And then later I was with the Chronic Center, working at a lot of data modernization related projects, specifically focused on chronic conditions. So I want to say this is sort of like, I keep pinching myself every day. It's really a dream come true to be here and serving the nation's public health infrastructure and data modernization efforts.
That is amazing. There's so many things that I kind of internally made a note to ask you about later, which is incredible. I really wanted to first ask a little bit about the fellowship experience, because number one, I love, and this is a great reminder that even if you may not necessarily feel qualified on paper, just to go for it, because you never know what happens. But I also feel that fellowships are great because it allows you to kind of make that transition, and you were kind of able to do that as well. Would love if you can kind of talk a little bit more about, you know, the experiences, what you learned, kind of how that enabled you to kind of make a specific jump that you were looking to make.
Absolutely. So there are many fellowships at the CDC, and if anyone is interested, I would recommend going to cdc.gov/fellowships to kind of take a look at the different opportunities. But the specific fellowship that I was part of is called the CDC Public Health Informatics Fellowship Program. And this is actually a 2-year applied fellowship program that is open to anyone with a master's degree with 1 or 2 years of experience, and anyone with a PhD or any level of doctoral level degree with at least 1 year of experience working in information technology, information science related projects. So at that point, when I applied, was in 2014, they had very specific eligibility criteria where I could not really apply because I think it was asking for completion of PhD. I was still doing my PhD. I was completing my dissertation, was near final, but did not graduate yet. And they were looking for more people with an information technology or computer science background. But I really liked the whole description and some of the projects that was mentioned in the fellowship eligibility page as past projects. So I thought, okay, let me give it a chance and I'll just go ahead and apply. It just so happened, what happens with the fellowship, they basically match you to applied projects that they have within CDC or with the state and local health department. So you're basically working on applied projects. So it's slightly different from the regular academic postdoctoral fellowships in the way that this is more applied in nature compared to the research nature of a postdoc academic fellowships. So you're basically working on applied projects and you're matched to a specific project which matches your skill set. So it just so happened that they were looking for somebody with a behavioral science background, who had some background in gamification, which was what essentially what I was doing as part of my PhD and also my work experience at the university. They also wanted somebody with an aptitude for technology and programming. So I had demonstrated that during the course of my work as well. So it was almost like this particular applied project was tailor fit for me. And I went through the process. The first time I was not selected. And it's after that process was completed, this particular applied project came up at the CDC, and they were like, okay, this person fits this profile to the T, so let's see whether she's interested. And that's how I ended up there. And I also want to add, I was not a US citizen at that point, and it's very hard for non-US citizens to get into any training or fellowship opportunity with the federal government. There are far and few, there are many opportunities, but you have to dig for it. And this was one of those fellowships that I could get in. So for me, as a first generation brown woman doing a STEM degree at the US, this was really, really something significant that I could get in and be part of something that I cherish, that kind of matches my value system and is also able to do meaningful work. So that's how I ended up at the CDC. So anybody considering fellowships or training opportunities, going back to your point, Nina, even if you think you're not eligible, I would just say give it a chance. If that matches what you're looking for, you never know how it could work out.
I love that. That is a success story. I mean, that's incredible that it really was the right opportunity, exactly what you were looking for, that matched your background. I think it was the universe telling you that this was where you were meant to go. Really now kind of wanted to ask a little bit more. You had mentioned with some of the work that you were doing kind of within the public health arena around maternal child health and some of the work and like interventions that you were creating. I'm just so curious, would love if you could share a little bit more about any learnings that you got when it came to, some of the very real barriers that you see whether it's education, access, etc. Just so curious to learn more about that.
Absolutely. So as I mentioned, I work within this very niche field of informatics, which I consider it is a very layered and multidisciplinary field. So you don't necessarily have a lot of women in informatics in the first place. And I've also seen people of all academic and work backgrounds embracing informatics and making it their own home. So you can see clinicians, public health researchers, behavioral scientists, economists, etc., working in this field. So it's also a borrower discipline. It borrows generously from multidisciplinary areas to kind of strengthen its application. So the reason I'm mentioning all of this is my work within CDC, and also what I am passionate about kind of is within this context of informatics. So making public health more accessible via technology, making sure that the right data is reaching the right people at the right time for right decision making. That's essentially what informatics is all about. So as you all know, data can be biased depending on who collects it, who analyzes it, who reports it out. So informatics really is making sure that principles of equity, inclusion, diversity is all applied in the science of collecting data and routing it for the right analysis and reporting out, and making sure that we can make right decisions using the right data. So that's really the essence of it. So across my career, I have seen different barriers, especially for underserved, marginalized population, especially for women, when the data is probably not collected, first of all, or even when you're sort of analyzing it, you're not analyzing it with the right context. That kind of obviously affects how interventions are designed. And I always kind of go back to this quote from Dr. Ambedkar. Said, I measure the progress of a community by the degree of progress which women, and I will also add children, have achieved. So that's always my yardstick of any intervention, policy, or information system that we create. Are we able to serve the most vulnerable, the most marginalized? I don't know if that answers your question, but I'm happy to kind of go through examples.
Yeah, I mean, I would definitely love some examples, but I really like how that's kind of been a tenet for you and really something that's enfolded, it seems like, into the DNA of everything that you're doing, to really think about it from that lens, because that is such an important one to take. But yeah, if you have any examples of just, how you've seen this just with your wealth of like lived experience, that would be amazing.
Absolutely. So as I mentioned, I worked in South Asia, especially in like really underserved, most vulnerable, with most vulnerable populations. So one lesson I've learned is public health really cannot be isolated from its context. So you can do all the research you want, you can have the perfect intervention, but if you're not tailoring it or customizing it with cultural humility towards its context, it would never work. And I have so many hilarious examples. We could kind of go on and on. But in the interest of time, I'm just gonna want to cover a couple of different points that's very relevant to our context here within the US. So for example, women and underserved populations often have different health needs than men, and the majority of the population. So for example, when women are more likely to experience certain chronic diseases, or they're also more likely to be victims of violence and abuse. And let's take a concrete example. US has the highest maternal death rate, particularly for Black women, compared to any developed nation in the world, which is very, very sad and disappointing. And if you actually look at the 2021 data, maternal deaths rose a staggering 40% compared to the previous year. So some of this might be attributable to COVID, but even pre-pandemic, maternal mortality rates within US was already steadily increasing. How did we really get here? We are a developed nation. So in the United States, if you look at the data, it's said that about 6.9 million women have little or no access to maternal health care.
Wow.
And CDC estimates about 80% of these pregnancy-related deaths are actually preventable. So these are deaths that we can actually prevent, that unfortunately we are not able to do at this point. So we have to do better. And this is a clear indicator that something is wrong within our healthcare system and really needs drastic changes. And we must continue to raise the subject and advocate for systematic investments and improvement across the board. So it's not just one healthcare provider's issue. It's not just the government's issue. It needs a systemic solution. So we need to make sure that consistent pregnancy care is available at all levels of the society, and starting with underserved communities. So only then we'll be able to kind of reverse the damage and, theoretically save lives of both mothers and babies, because everybody wants to save babies' lives and moms. So that's just one example. If you actually, look through every single health issue or public health issue, you can really see concrete disparities across the board like that. And we need to kind of start thinking about system-wide changes and solutions. And not to mention, public health is always drastically, chronically underfunded. That kind of had a shift during the pandemic, because we saw how much of that it really impacts our daily lives. But public health is really an invisible discipline. When it works, and nobody really notices it. When something goes wrong, all hell gets loose. So I'm probably preaching to the choir, but that's something which I'm really passionate about, that making sure that we reach the most underserved, the most vulnerable, and that's always going to be my yardstick and my North Star.
That's absolutely incredible and so inspiring. Everything you said, I was just saying yes in my mind. Also kind of wanted to ask too, I think, you really demonstrated the impact of having a lens that is inclusive, that does kind of take these into consideration when we think about the populations that are being served, but also what about kind of internally, when you think about the teams, when you think about those on the inside within public health policy, data, et cetera, why is it important to really include them and have that diversity even in-house?
Absolutely. And I have had the fortune to work with a lot of women leaders, brilliant women leaders, and we need more women at the table, and not just any table, at the decision-making table and where our voices are heard. In US, we are women is about 51% of the population, so it's about time we get represented. And I really recommend this book called Invisible Woman. It's by Dr. Carolyn Criado Perez. It basically talks about exposing data bias in a world designed for men. And again, I have nothing against men. I'm just advocating for gender inclusive, equity-based, empathetic policies that make sure that everyone is treated equal, and we design policies and interventions that help us get to more equitable health outcomes. So with that context, one of the examples this book talks about is how women are 47% more likely to get severe injuries in car crashes than men. And that's because the dummies they use for crash testing by manufacturers, they represent the male body proportions and do not take into account female body or how women drive, because we sit up, we go closer to the steering wheel. None of that is taken into account when the crash testing is done. There are so many blind spots like these in any product or in any information system that we can look at. So we need more representation in clinical trials. We need more representation in boardrooms. There are many ways to address this data bias, including collecting more data on women, using gender neutral language and making sure that, products and services are designed for everyone, making sure that opportunities are given equally. So I always advocate for women representation. If I'm going on a panel, I ask, are there other women? Are we equally represented? So if you can raise your voice, if you have a voice, just make sure that you raise for everyone who is underrepresented.
That is absolutely incredible. And I love that. That's such a good practice, I think, to really, just do all of that, even at like a quote unquote local level with what you can influence or be a part of. I think that is incredible. And wanted to ask too, I think when we think about everything that's happening with data and like generative AI and all of these things, I think now a lot of this is really being put at the forefront of, I think, the cultural mind. Would love to share a little bit. I don't know if you've kind of thought this through, but I think, when we think about almost design principles for generative AI or for data as it continues to mature, that is very inclusive. Is that something that you kind of thought about, or at the CDC that there's kind of work around kind of developing it or designing it the right way? Just curious about that.
Absolutely. We are and again, I'm not speaking for the CDC. Again, I'm just giving my personal perspective and my experience. There is a lot more interest, and also more people are coming together to make sure that there's intentional design to help we align to the diversity, equity, and inclusion principles. So every single project we undertake, that question is consistently raised about health equity, about are we doing it the right way? Obviously, we will make mistakes, but it's about learning from them. I could go on and on about this topic because it's one of my pet peeves. We all know data is powerful. It is a powerful lever for decision making. Everybody is looking at it to interpret it and make sure that we uncover meanings. And with AI, like you said, you have millions and millions of data points that's available to help us make these decisions. But I'm pretty sure everyone is aware of it. Data is not really neutral, right? It is collected, it's analyzed, interpreted, like I mentioned earlier, by people, and these people bring their own biases to the table. It's also collected in a context or social situation which already has inherent biases. As a result, data can often reflect the biases of the people who created it. So not even going to the extent of like AI and big data analysis, like simple things. I'm very passionate about data visualization. So simple things like you look for icons, like a nurse icon or a Bose icon, you clearly see a demarcation of the visuals that come up in the image search. So right from the choice of colors you choose to represent a marginalized population, why is red represented for a particular group of people all the time? Because red has a certain connotation in our subconscious mind. So maybe not use that color. And there are really good guidelines, like both federal government and also external agencies have come out with more research. So trying to look at the most updated research and the best practice out there to make sure that we are following the DEI principles, that's definitely something that myself as well as my colleagues practice. I know every HHS agency has very clear guidelines on representing health equity, and both in language and visualizations and so on. So right from the color of the icons to the labels that we use, how we represent a particular group, the language we use to kind of connote meanings, we're becoming extremely mindful about that. And there are many principles and techniques, and a lot of research is done in this area. It's still an emerging field. Like I said, the important thing is we learn from mistakes. And again, one yardstick I like to think about is, if I become a data point in a visualization, will I be offended with that? Do no harm. And Urban Institute has a really good policy guide, which includes specific bullet points and actionable items about how you can make data visualizations equitable and inclusive. And that's something which I would highly recommend to anyone who's interested in that. And ultimately, anything related to data is also about storytelling, right? So we need to make sure that we are telling the right story empathetically and also with humility, because you are responsible for telling someone else's story. So that's a powerful responsibility, and it's kind of cliched, but with great power comes great responsibility.
And I loved how you really outlined, I think, just a very actionable, I think, just step that all of us can take. I know I'm definitely going to do an audit to just see, there's some things that with your own bias that you don't even really think about. So I really like that you kind of outlined a good stepping stone, I think, for all of us when we think about this work and how we represent and the stories that we tell. That's incredible. I know we only have 1 minute, so just wanted to end. I feel like I could just go on and on. There's so many questions that I have for you. We'll definitely need to bring you back, but would love if we can end our discussion, if you could share. I think one of my favorite questions to ask is if you have any words of wisdom that you would like to impart on the audience today, anything that a mentor had told you, anything that you've just learned that you want to share with us.
That's a great question. And I wish I had one answer. I have like multiple answers, but if I can give you just one response in the interest of time, if you're looking for a career or, trying to move on, you have learned what you need to do for today's workspace. Always think about what is going to happen in the next 10 years. And there are seismic shifts that's happening. So what you really need to prepare for is careers of tomorrow. And I'm not really sure whether anyone is really training for that. So just make sure that you're always updated. Continuous lifelong learning is really, really important in health, public health and health information technology, I feel. So be prepared for the future when you're anchoring yourself to the current space. So that would be my words of wisdom.
I love that. I think we'll have to bring you back and you can share the other words of wisdom that you have for us.
Absolutely. Thank you so much for having me. It was